Welcome to our deep dive into U.S. healthcare.
All right.
You gave us a ton of articles and reports.
Yeah.
And it seems like you're pretty interested in the cost of healthcare.
I am.
Things like physician salaries, what procedures cost,
Yeah.
all the red tape.
You got it. You've hit the nail on the head.
Okay.
And what's so fascinating is how all these seemingly separate issues are all tangled up.
Right.
We'll see how decisions made in Washington or at insurance companies can ripple out and affect everything from how much your doctor earns to what your experience is like as a patient.
Well, let's start with something that affects us all.
Okay.
The price tag on medical procedures.
All right.
I mean, we're seeing some big changes coming up in 2025 with this Medicare physician fee schedule.
Yeah, the Centers for Medicare and Medicaid Services, or CMS, recently announced that physician payments are going down by an average of 2.93% compared to 2024.
Now, you might think, okay, 2.93%, that's not huge. But in a system where costs are already skyrocketing and we're facing a shortage of primary care doctors, even a small dip like this can make a big difference.
Exactly, especially for those on Medicare.
Right.
There are a few reasons for this payment reduction.
Okay.
One is that a temporary payment boost they had in 2024 is expiring.
Okay.
The other has to do with something called work RVUs.
Work RVUs? What in the world are those? That sounds like something out of, like a sci-fi movie.
I can see why you'd say that.
Yeah.
Work RVUs stands for relative value units.
Okay.
It's basically a way to measure how much work goes into different medical procedures.
Oh.
They factor in things like the time it takes, the skill required, and how intense the procedure is.
So more complex procedures like open heart surgery would get more RVUs than, say, a routine checkup.
You got it.
Okay.
And the more RVUs a procedure has, the higher the payment the doctor gets for doing it.
So that makes sense.
But here's the catch. The way this system is set up, it tends to favor those specialized procedures over primary care.
Okay.
That's one of the big reasons why we're short on primary care doctors. It's just not as financially rewarding.
That makes sense. It's all about incentives.
Right.
And speaking of incentives, one of the articles you sent,
that
KFF Health News piece, compensation is key to fixing primary care shortage, really digs into how this payment structure creates a big income gap between primary care doctors and specialists.
Absolutely. It's a huge problem.
Yeah.
The article mentions that primary care physicians earn on average between $250,000 and $275,000 a year.
Wow.
But specialists like plastic surgeons, orthopedists, and cardiologists can earn more than double that.
Yeah.
It's no wonder med students are flocking to those specializations.
Yeah, if you're graduating with hundreds of thousands of dollars in student loan debt, that income difference is hard to ignore.
It is.
It's inspiring to see people like Anitza Quintero, who's featured in the article. She's a med student who chose primary care, even though she knew she could make a lot more money as a specialist.
Yeah.
She's proof that passion can sometimes outweigh those financial pressures.
I agree. She's a great example. And her story highlights the need for creative solutions to attract more people to primary care. The KFF article mentions this program called the Abigail Geisinger Scholars Program.
Okay.
They offer to forgive med students loans.
Wow.
If those students commit to working in primary care for Geisinger.
Okay.
It's a really promising model, especially for getting doctors into areas where they're desperately needed.
That's a great initiative. It makes you wonder why more places aren't doing things like that.
Right.
But there's another layer to this whole cost issue, isn't there?
Yeah.
It's not just about how doctors get paid, but also all the administrative costs in the healthcare system.
Right. It's mind-boggling how much money gets wasted on administrative stuff.
Right.
The Center for American Progress did a report called Excess Administrative Costs Burden the U.S. Healthcare System, and it paints a pretty bleak picture.
It seems like there's always a new form to fill out a new approval to wait for.
Yeah.
It makes you wonder if anyone is actually focused on patient care anymore.
Right.
But I also know some administrative work is necessary to keep things running smoothly.
Right. Absolutely. The report makes a clear distinction between administrative costs that are necessary and those that are just wasteful.
Okay.
We're not talking about cutting corners on patient care or a doctor's ability to make good decisions.
Right.
It's about getting rid of the clunky, unnecessary processes that just bog everyone down.
Okay, so what does this waste actually look like? Give me some concrete examples.
Well, think about all the billing and coding that goes on. The system is so complicated that it can lead to errors, overcharging, and even outright fraud.
Oh, wow.
Then there's the mountain of paperwork associated with insurance companies.
Oh, yeah.
Doctors and hospitals spend an insane amount of time and resources just dealing with insurance-related tasks. It's no wonder they're burned out.
Tell me about it. I feel like I need a PhD just to understand my own health insurance plan.
Right.
And don't even get me started on prior authorization.
Oh, yeah.
It's supposed to save money,
Right.
but it often just delays care and creates more frustration for everyone.
You're preaching to the choir.
Yeah.
Prior authorization is a huge headache, and the report lays out a few potential ways to tackle this administrative monster.
Okay.
Some of the solutions are pretty sweeping, like changing how we pay for healthcare altogether.
Like what?
They talk about things like all-payer rate setting,
Okay.
where everyone pays the same amount for a given service,
Okay.
or even a single-payer system where the government is the one paying for everyone's healthcare.
Those are pretty big changes.
Yeah.
It makes me wonder if there are smaller, more targeted things we could do that might be easier to implement.
The report highlights some proposals from a group of researchers led by a guy named Sani.
Okay.
They've written about this in both a McKinsey report and a JAMA article. They break down potential solutions into 3 categories: within, between, and seismic.
Okay. Break that down for me. What does all that mean?
Okay, within interventions are things that individual organizations like hospitals or clinics can do on their own.
Okay.
This could be streamlining how they process claims or automating some tasks.
Right.
Between interventions involve multiple organizations agreeing to do things differently.
Okay.
For example, they might align their criteria for prior authorization so it's not such a chaotic mess.
Okay.
And finally, seismic interventions are those big industry-wide changes I mentioned earlier, like switching to a single-payer system or creating a central system for processing everyone's claims.
It sounds like we need a mix of all 3 types of interventions to really get a handle on this administrative mess.
I think so. And honestly, one of the most promising solutions, at least in the short term, is switching to electronic prior authorization system. There's this organization called CAQH, and they have estimated that going fully electronic with prior authorization could save the healthcare system a whopping $417 million every year.
It's amazing how much time and money we're wasting just because we're clinging to these outdated processes.
It really is. Thankfully, there's some momentum building towards making these changes.
Okay.
Big groups like the American Medical Association and AHIP, that's America's health insurance plans, are pushing for electronic prior authorization standards.
Fine.
And CMS has proposed a rule to streamline the whole prior authorization process.
Okay.
If that goes through, it could be a huge relief for both doctors and patients.
It sounds like there's hope on the horizon.
Yeah, but the Center for American Progress report also makes a really important point about the need for intervention from the top down.
Okay.
Especially when it comes to standardizing processes across public and private healthcare entities.
Okay.
The problem is that often the folks who are making the system more complex aren't the ones who end up paying the price for it. Right.
Someone else gets stuck with the bill, literally and figuratively.
Right.
So we need some higher level changes to ensure everyone is playing by the same rules.
Yeah, I agree.
You know?
I think that makes sense.
Yeah.
Okay, so we've talked about how doctors get paid and all the administrative headaches in the healthcare system, but what about the doctors themselves?
Right.
Yeah. How are they holding up under all this pressure?
That's a crucial question. And it brings us to this concept of moral injury in healthcare.
Moral injury?
Yeah.
I've never heard that term before.
Okay.
What does that mean exactly?
It's this feeling of deep distress that doctors and nurses experience when they're unable to provide the care they know their patients need because of limitations imposed by the system.
Oh, wow.
They feel like their hands are tied, and it can be incredibly demoralizing.
Yeah, I can see how that would lead to burnout. Exactly. The Commonwealth Fund did a report called Transforming Care, Burnout and Moral Injury Among Clinicians. And it's a really eye-opening look at how these issues are affecting healthcare workers.
Okay.
One story that really stuck with me was about an emergency room doctor who kept warning the hospital administrators about being dangerously understaffed. They ignored his warnings, and tragically a patient died in the ER while he was covering for a lack of staff elsewhere.
Oh, that's just heartbreaking. It really drives home the point that these systemic issues have real-life consequences for both patients and providers.
Absolutely. And the report stresses the importance of providing support to healthcare workers who are dealing with these kinds of traumatic experiences.
Right.
It mentions a program at Ohio State University called BEST,
Okay.
which stands for Brief Emotional Support Teams.
Right.
They provide training and support to healthcare workers who have been through these tough situations. It's great to see initiatives like that emerging.
It sounds like a much-needed resource, but moral injury isn't just about isolated traumatic events, is it?
No, you're right.
It's also about the day-to-day grind of working in a system that often seems to prioritize profits over patient care.
It's that constant pressure that's wearing doctors down. The report talks about the growing cognitive burden on clinicians. They have to keep up with more and more treatment protocols, documentation requirements, performance measures.
Yeah.
And of course, all the complexities of the American payment system. It's a lot to juggle.
The report shares a story about an internal medicine physician named Dr. Ranjit Tamaskar.
Right.
He says he feels torn between really listening to his patients and just trying to check all the boxes during their limited time together.
Yeah.
I think that really sums up the dilemma facing many clinicians today.
It does. And remember that prior authorization process we talked about earlier.
Yeah.
That's a major contributor to this cognitive burden, too.
Right.
Doctors are spending hours filling out paperwork and fighting with insurance companies, and it takes away from the time they could be spending with their patients.
It's so frustrating. But it's not all doom and gloom, right? The Commonwealth Fund report also highlights some potential solutions to address these challenges.
Right. It mentions a few efforts to reduce the burden of prior authorization, for example. Texas has this thing called the Gold Card Bill.
Okay.
Which exempts doctors from needing prior authorization for certain services if they have a good track record of getting those services approved in the past.
So that sounds like a step in the right direction. I wonder if other states are considering similar legislation.
They are. There are actually similar bills being considered in a number of other states, and even CMS is stepping up with a proposed rule to streamline the whole prior authorization process.
Okay.
These are positive signs that people are starting to take this issue seriously.
It feels like there's some momentum building. I hope it continues. The report also talks about this idea of a DIED model of healthcare management. What is that exactly?
It's a model where physician leaders work side by side with hospital administrators to make decisions. The idea is to bring clinical expertise back into the decision-making process, so it's not just about the bottom line.
That makes a lot of sense. I'm all for anything that gives doctors more say in how things are run, but the report also acknowledges that it can be tough for clinicians to speak up and advocate for change, especially since many of them are employed at will and have a ton of student loan debt.
Yeah, it's true speaking out can be risky, especially if you're worried about losing your job or being penalized financially. That's why it's so important to create supportive work environments where clinicians feel safe to voice their concerns and share their ideas.
Absolutely. Leaders need to be willing to listen to their frontline staff and take their concerns seriously. There's also some positive movement on the legislative front. The report mentions the Dr. Lorna Breen Healthcare Provider Protection Act of 2022.
Right.
It's named after a doctor who tragically took her own life during the early days of the COVID-19 pandemic.
Right.
The act aims to expand access to mental health care and treatment for healthcare providers, and it provides funding for programs to promote mental health and resilience.
That's so important. We need to take care of the caregivers if we want them to be able to take care of us. The report also highlights the work of an organization called the Workplace Change Collaborative.
Okay.
They're working with healthcare organizations and public safety agencies to test out different strategies for creating more supportive workplaces. It's encouraging to see that kind of work happening.
It sounds like there are a lot of people working on different pieces of this puzzle.
Yeah.
But it also feels like we need some bigger, more systemic changes to truly fix the healthcare system.
Yeah.
I'm curious to hear more about some of those alternative approaches you mentioned earlier, like comprehensive healthcare for America.
Right. That's where things get really interesting. Before we jump into that, let's take a closer look at some of the data about how doctors are being compensated and how these systemic issues are playing out in the real world. Would you be interested in diving into that a bit?
Absolutely. I think data can be really helpful in understanding the big picture and seeing where the problems are most acute.
Okay, great. One of the reports you sent, the MGMA's 2024 Provider Compensation Data Report, offers a ton of insights into physician earnings, those work RVUs we talked about earlier, and the strategies medical practices are using to navigate this complex landscape.
I'm ready to geek out on some data.
Perfect. Let's start with those work RVUs again. The report breaks down the median number of work RVUs for different medical specialties, and there are some interesting differences.
Like what?
Well, for example, in 2023, invasive cardiologists had a median of around 6,400 work RVUs. But family medicine physicians without obstetrics had a median closer to 4,500.
So even though cardiologists get paid more per RVU, they're also doing procedures that have a lot more RVUs attached to them. It makes sense that their overall earnings would be higher.
Exactly. It reflects the higher intensity and complexity of the procedures they're doing, but it also highlights the challenge of fairly compensating primary care doctors who are providing essential care but often aren't doing as many procedures.
It seems like we need to find a way to better value primary care if we want to solve the shortage problem.
I agree. The report doesn't just present the data, though it also includes insights from consultants who are working directly with medical practices to help them figure out how to stay afloat financially while also preventing physician burnout.
I bet they have some fascinating stories to tell. What kind of advice are they giving to practice leaders?
They're really emphasizing the importance of making things run as smoothly as possible. That means streamlining processes, optimizing workflows, and really leveraging technology to reduce the administrative burden on doctors.
So it's all about working smarter, not harder.
Exactly. They're suggesting all sorts of strategies from automating routine tasks and reviewing contracts with vendors to optimizing patient flow and inventory management. They're also encouraging practice leaders to empower their teams, involve them in finding ways to improve things, and create a culture of open communication.
It sounds like a more collaborative approach to running a practice.
It is, and the consultants are recognizing that technology, especially artificial intelligence or AI, is going to play an increasingly important role in making healthcare more efficient and reducing workload.
It's amazing how AI is starting to make its way into every aspect of healthcare, from scheduling appointments to helping doctors diagnose diseases. It makes you wonder what the future holds.
It does, and the report emphasizes that healthcare leaders are realizing they need to get up to speed on AI if they want to stay competitive.
It's a whole new world out there. But as exciting as all this new technology is, we can't forget about the human side of healthcare. We need to address those underlying systemic issues that are contributing to burnout and moral injury.
Absolutely. And that's where the conversation about how we pay for healthcare comes back into play. The MGMA report dives into how medical groups are designing compensation plans that reward doctors for providing high-quality care and keeping their patients satisfied.
I've heard a lot about value-based care lately. Is that what you're talking about?
Yes, that's part of it. It's this shift away from just paying doctors for the number of procedures they do and towards paying them based on the quality of care they provide. It seems like there's a growing trend towards incorporating quality performance metrics into doctors' compensation plans.
That sounds like a good idea in theory, but is it actually happening in practice?
It's a mixed bag. MGMA did a poll in April of 2024, and they found that 50% of medical groups were including quality performance metrics in their compensation plans, but the other 50% were not.
Wow, it's a perfect split down the middle. Why do you think some organizations are hesitant to make that shift?
There are a few reasons some groups just aren't convinced that value-based care is the way to go. They're worried about making the transition during a time when there's a lot of instability in the healthcare workforce, and some are just overwhelmed by the complexity of implementing these new systems. It's not easy to change how you've always done things.
I can imagine it sounds like a big undertaking.
It is. The report emphasizes the need for clear communication from leadership, a shared understanding of the goals of value-based care, and strong support for everyone involved. And it's important to involve doctors in the process of developing these new compensation models. After all, they're the ones who will be most affected by them.
It makes sense to get their input and buy-in from the start. Did the MGMA report say anything about how often doctors are actually involved in these decisions?
They did another MGMA poll, this one from March of 2024. Found that 60% of medical group leaders said their doctors were involved in developing the compensation methodology.
That's encouraging to hear. It sounds like there's a movement towards greater transparency and collaboration in how doctors are compensated.
I think so, but compensation is just one piece of the puzzle. The report also talks about the importance of creating a work environment that supports doctors' well-being and helps them feel good about the work they're doing.
That makes sense. It's not just about the paycheck. It's about feeling valued and respected and knowing that you're making a difference.
Exactly. The report highlights things like having strong support staff opportunities for professional development and a healthy work-life balance as key factors in retaining doctors.
It's interesting how those things often go hand in hand with efforts to improve the quality of care and reduce burnout.
You're right. When doctors feel supported and appreciated, they're more likely to be engaged in their work and provide better care to their patients.
So we've talked about how doctors get paid, the challenges of creating supportive work environments, and this shift towards value-based care. But there's another layer to this whole compensation issue, isn't there?
Yeah.
It's how much insurance companies are willing to pay doctors for their services.
Right.
And that can have a big impact on patient access to care, especially for people on Medicare.
You're absolutely right. And MGMA actually has another report that dives into that very issue.
Okay.
Their annual regulatory burden report from November 2023 takes a hard look at how all the red tape and regulations in healthcare are affecting patient access to care.
I'm guessing it's not a pretty picture.
It's not. This report is based on a survey of executives from over 350 group practices.
Yep.
So it gives us a good sense of the challenges doctors are facing on the ground. And the findings are pretty alarming. A whopping 94% of respondents said that the move towards value-based care in Medicare and Medicaid has not reduced the regulatory burden on their practices.
That's a huge majority.
Mm-hmm.
It seems like value-based care hasn't lived up to its promise of simplifying things for doctors.
Unfortunately not. And what's perhaps even more worrying is that 75% of the respondents said that current Medicare payment rates are a major factor impacting their patients' access to care.
That's a real problem.
Yeah.
It means that the financial pressures on medical practices are having real consequences for patients, especially those who rely on Medicare.
Exactly. And when we look at the specific challenges practices are facing, prior authorization emerges as a major pain point. A staggering 89% of respondents said that prior authorization requirements are very or extremely burdensome.
Wow.
It's a huge drain on their time and resources.
It sounds like a never-ending battle with insurance companies.
It often feels that way, and it's not just the doctors who are suffering. A whopping 97% of practices said that their patients have experienced delays or denials in getting the care they need because of prior authorization requirements.
That's a shocking statistic.
Yeah.
It means that patients are facing unnecessary roadblocks in getting the care they need. It makes me wonder if anyone is looking out for the patients in this whole system.
It's a valid question, and the report digs into the top challenges associated with prior authorization.
Okay.
The biggest issues seem to be delays in getting decisions from insurance companies, inconsistent policies across different payers, and the fact that prior authorization is often required for treatments that are routinely approved.
It just seems so unnecessary, like the system is designed to make things more difficult for everyone involved.
That's how it feels sometimes. And the report also raises some concerns about the Medicare Quality Payment Program, or QPP,
Okay.
which was designed to encourage doctors to provide high-quality care.
It's ironic that a program meant to improve quality of care is actually adding to the paperwork and hassle for doctors and potentially making it harder for patients to get the care they need.
Right. The report found that 69% of practices are participating in MES-BIS, which is the most common track within the QPP.
Okay.
But there's a lot of skepticism about whether it's actually making a difference in patient care.
How so?
Well, 72% of respondents said that the move towards value-based care has not improved the quality of care for their patients, and 68% said that paying doctors based on value hasn't been successful so far. It seems like there's a disconnect between the goals of these programs and what's happening in the real world.
It highlights the need to constantly evaluate these programs and be willing to adjust them if they're not working as intended.
Absolutely. The report also looked at something called Advanced Alternative Payment Models, or APMs.
Okay.
These are payment models that are supposed to be more patient-centered and focused on outcomes than traditional fee-for-service models.
I've heard about those. They sound promising, but are they actually working?
The jury's still out. Only 56% of the respondents said that Medicare offers an advanced APM that's relevant to their practice.
Okay.
And even among those who said a relevant APM exists, only 24% expect to achieve qualifying APM participant status for the 2023 performance year.
So it sounds like there are still some barriers to entry and participation in these new payment models. Maybe they're too complex, too risky financially, or maybe doctors just don't understand how they work.
That could be part of it. The report highlights the need to provide more support and education to practices that are considering switching to these alternative payment models.
So we've got prior authorization nightmares concerns about the effectiveness of value-based care and challenges with implementing these new payment models. It's a lot to take in.
It is, but amidst all these challenges, there are also signs of hope and innovation.
Okay.
The MGMA reports emphasize the importance of collaboration between doctors and administrators, the potential of technology to streamline workflows, and the ongoing efforts to improve how we pay for healthcare.
It's a reminder that even within a complex and often frustrating system, there are people working hard to make things better for both patients and providers.
Right, and speaking of making things better, remember those alternative approaches to healthcare we touched on earlier, like comprehensive healthcare for America.
Yeah.
I think it's time to delve into those and see if they offer any solutions to the challenges we've been discussing.
Okay, so let's talk solutions.
Yeah.
We've covered a lot of ground.
Yeah.
Yeah. How doctors get paid,
Uh-huh.
mountains of paperwork,
Yeah.
emotional toll.
Right.
It's easy to feel overwhelmed by all the challenges.
It is.
But I'm curious to hear more about these big picture ideas for fixing healthcare.
Yeah.
Like that comprehensive healthcare for America proposal we touched on earlier.
Right. It's definitely time to shift gears and think about how we can build a better system.
Okay.
That Journal of Medical Ethics article, Comprehensive Healthcare for America, using the insights of behavioral economics to transform the U.S. healthcare system, lays out a pretty interesting vision.
I remember it talked about this idea of using behavioral economics to design a healthcare system people would actually want to use.
Yeah.
Can you remind me how that works?
Yeah, behavioral economics is all about understanding how people actually make decisions, not just how we think they should make decisions.
Okay.
And one key insight is that people are often swayed by things like inertia and the path of least resistance.
So you mean we tend to stick with a default option, even if it's not the best choice for us? I know I'm guilty of that.
We all are. And the CHA proposal takes advantage of that by making enrollment in their program automatic.
Okay.
So instead of having to actively sign up for health insurance, you'd be automatically enrolled unless you specifically chose to opt out.
It's kind of like how a lot of companies are doing 401k enrollment now.
Right.
You have to check a box if you don't want to participate.
Exactly.
Rather than checking a box to opt in.
That's a great analogy. And the article argues that this kind of automatic enrollment has been very effective in getting people to participate in retirement savings plans and even health insurance programs like CHIP, the Children's Health Insurance Program.
It makes sense sometimes we just need a little nudge in the right direction, especially when it comes to something as important as health insurance.
Right.
But does that mean CHA would basically eliminate private insurance?
Not entirely. One of the things that makes CHA different from a traditional single-payer system is that it gives people the option to opt out.
Okay.
If someone really wants to stick with their private insurance plan, they can.
That seems like a smart move politically. It acknowledges that people value choice.
Yeah.
And might be wary of a fully government-run healthcare system.
Right.
But wouldn't having an opt-out option undermine the whole point of creating a universal healthcare system?
The authors of the CHA proposal don't think so. They argue that most people would choose to stay in the program once they saw the benefits, comprehensive coverage, simpler rules, and potentially lower costs. They predict that only a small percentage of people would actually choose to opt out.
It would be interesting to see how that would play out in real life.
It would.
But let's back up a bit. What exactly would be covered under CHA? Would it just be the same stuff that's covered by traditional Medicare now?
CHA actually aims to be much more comprehensive than traditional Medicare.
All right.
It would cover all the essential services, including things like dental care, mental health services, vision care, and even long-term care.
Wow, that's a big difference. Those are services that a lot of people struggle to afford right now.
You're right, and because CHA would be a single unified system, it would also do away with all those confusing different plans, deductibles, and coverage limitations that people have to navigate now.
That'd be a huge relief. It's like healthcare would finally make sense. But how would CHA actually make those decisions about what's covered and what's not? Who gets to decide?
That's a great question. The CHA proposal suggests creating independent boards of experts to make those coverage decisions.
Okay.
Similar to how the United States Preventive Services Task Force works now.
Yeah.
These boards would be made up of doctors, scientists, and other healthcare professionals, and they would use the best available evidence to make recommendations about which treatments and services should be covered.
So it would be like taking the politics and the profit motive out of healthcare decisions and putting patients first.
That's the idea. It's about ensuring that people get the care they need based on what science tells us works, not based on what insurance companies are willing to pay for or what politicians are pushing for.
Okay, I'm starting to see how this could actually work, but we haven't talked about the elephant in the room yet.
Yeah.
How are we going to pay for all this?
Yeah.
I know a lot of people are worried that switching to a system like CHA would mean massive tax increases.
That's a common concern, but the article actually argues that CHA wouldn't necessarily require a huge tax hike. They propose using a combination of existing funding sources.
Okay.
Like Medicare funds, employer contributions, and taxes that are already being used to support Medicaid. They also point out that a single-payer system like CHA could potentially save a lot of money by by streamlining administrative processes, reducing marketing and underwriting costs, and having more negotiating power when it comes to drug prices.
So the argument is that we're already spending a ton of money on healthcare.
Right.
But we're not spending very efficiently.
Exactly.
CHA would be a way to redirect those funds and make the system work better for everyone.
Exactly. And the authors of the article acknowledge that any major policy change like this will come with challenges. They talk about the need to address concerns about long-term financing, sustainability, and potential political opposition. They also acknowledge the debate about using cost-effectiveness analysis to make coverage decisions, which is always a sensitive topic.
It sounds like they've thought this through pretty carefully. It's not a perfect solution, but it's certainly a thought-provoking alternative to the mess we have now.
I agree. CHA offers a compelling vision of a future where healthcare is truly a right, not a privilege. It's a reminder that there are different ways to structure a healthcare system, and we don't have to settle for the status quo.
I think that's the key takeaway from this whole deep dive. We've explored the data, we've heard the stories, we've seen how these different issues are all connected. Now it's up to us to demand better from our healthcare system.
You've hit the nail on the head. We've given you a foundation of knowledge, but the conversation doesn't end here.
Right.
It's time to take this information and do something with it.
So, to our listener, we ask, what will you do with this information?
Right.
What questions will you continue to explore? What actions will you take to advocate for a better healthcare system?
The future of healthcare is ultimately in our hands. Let's work together to create a system that prioritizes health, equity, accessibility, and the well-being of both patients and providers.
Thank you for joining us on this deep dive.
It's been a pleasure.
Keep learning, keep asking questions, and keep fighting for a better healthcare system. We'll see you on the next deep dive.